Hello, welcome to another podcast on surgical smoke. I've actually compiled quite a few articles about surgical smoke. There's some guidelines that the AORN have produced for surgical smoke safety, and the guideline for surgical smoke safety has been approved by the AORN Guidelines Advisory Group in December 15th, 2016. And surgical smoke is the byproduct of use of energy generating devices, for example, electrosurgery units, lasers, power instruments. And when surgical energy devices raise intracellular temperatures to 100 degrees Celsius or higher, the tissue vaporizes, producing surgical smoke plume. They call it plume. The gaseous byproduct is visible and malodorous. Surgical smoke may contain gaseous toxic compounds, hydrogen cyanide, toluene, benzene, bioaerosols, viruses, for example, human papillomavirus, HPV, human immunodeficiency virus, HIV, viable cancer cells, non-viable particles, for example, lung-damaging dust of 0.5 micrometers to 5.0 micrometers, carbonized tissue, blood fragments, and bacteria. The water vapor content of surgical smoke ranges from 1% to 11% and serves as a carrier for the compounds, viruses, and other substances. Researchers began analyzing the contents of surgical smoke in the early 1980s. In a 1981 study, Tomita et al. Found that the contents of surgical smoke are similar to the contents of cigarettes. That's 1981, with known and suspected carcinogens and mutagens. Electrosurgical devices use radio frequency current to cut and coagulate. Heat is generated in the body tissue through which the current passes. The heat causes cell walls to explode, releasing the cellular fluid as steam and the cell contents into the air, forming surgical smoke. Lasers produce an intense, coherent, directional beam of light and also produce high heat, which raises the temperature within the cell, vaporizing the contents and releasing steam and cell contents. Ultrasonic devices remove tissue by rapid mechanical action. Ultrasonic aspirators produce a fine mist, and ultrasonic scalpels produce a vapor. High-speed electrical devices, bone saws, drills, cut, dissect, and resect tissue. The mechanical action of the saw or drill combined with irrigation fluid used to cool the device produces aerosols that may contain viable blood-borne pathogens. The Occupational Safety and Health Administration, OSHA, has estimated that more than 500,000 healthcare workers are exposed to surgical smoke every year. Perioperative nurses report twice the incidence of many respiratory problems compared to the general population. Case reports have established the link between inhalation and surgical smoke during excision of anogenital condylomata procedures to transmission of HPV to healthcare providers. For example, a laser surgeon developed laryngeal papillomatomatosis of the same virus type as his patient. And experts at a virological institute confirmed a high probability of occupational exposure in gynecologic perioperative nurse who developed recurrent and histologically proven laryngeal papillomatosis. 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 Atuna macata. Papillomatosis. Proven laryngeal papillomatosis. Surgical smoke exposure is also hazardous to the patients. Risks to patients include loss of visibility in the surgical field during minimally invasive procedures, with potential to delay the procedure, port site metastasis, exposure to carbon monoxide, and increased levels of carboxyhemoglobin. Increased levels of carboxyhemoglobin. AORN, the National Institute for Occupational Safety and Health, NIOSH, and other professional organizations have recommended surgical smoke evacuation for more than 20 years. Perioperative team members continue to demonstrate a lack of knowledge of the hazards of surgical smoke and a lack of compliance in evacuating surgical smoke. Even though smoke generated by electrosurgery is more hazardous than laser-generated surgical smoke, there is greater compliance with smoke evacuation for laser procedures. Surgical smoke is often referred to as a surgical plume, smoke plume, bioaerosols, laser-generated airborne contaminants, and lung-damaging dust. For the purpose of this document, the surgical smoke will be used unless another term has been specifically used in a reference source. And there's evidence review according to the guidelines. A medical librarian in the 2017 guidelines for perioperative practice conducted systematic searches of the databases Medline, Cinal, which is CINAHL, Scopus, and the Cochrane database of systematic reviews. Results were limited to literature published in English from 1985 to November 2015. During the development of the guidelines, the lead author requested additional articles either did not fit the original search criteria or were discovered during the evidence appraisal process, and the lead author and medical librarian identified relevant guidelines. So, quite frankly, from government agencies and standards setting bodies, updated searches were completed in January 2016. Search terms related to procedures included the subject headings and keywords diathermy, cautery, laser, electrosurgery, and surgical procedures. Operative. Search terms and keywords related to products include smoke, plume, fume, exhaust, mist, particulate matter, bioaerosols, aerosols, smoke evacuation, smoke extractor, and occupational air pollutants. So inclusion criteria were research and non-research literature in English. Complete publications, publication dates within the time restriction unless none were available. Excluded were non-peer-reviewed publications and literature on surgical smoke safety. Letters and editorials were excluded. Low-quality evidence was excluded when higher quality evidence was available, and literature outside the time restriction was excluded when literature within the time restriction was available. So basically, recommendation 1, the healthcare organization should provide a smoke-free work environment. There's all types of chemicals in surgical smoke that they've found, and a few of them are acetylene, acrolein, formaldehyde, furfural, hexadecanoic acid, hydrogen cyanide, indole, methane, to name a few, xylene. The particles. Collective evidence indicates that the particles in surgical smoke generated by surgical energy generating devices are within the respirable range. Electrosurgery generates the smallest aerodynamic sized particles. Laser tissue ablation creates larger particles, and ultrasonic scalpels create the largest particles. RAGD, I don't know when this was, I conducted a study to assess the exposure of surgical personnel to ultrafine particles, to identify the predictors of exposure and to characterize the particle size distribution of surgical smoke. The researchers measured personal exposures for the surgeon, assistant, scrub nurse, and aesthetic nurse during 5 different procedures: nephrectomy, breast reduction, abdominoplasty, hip replacement, transurethral resection of the prostate, using spectrometry to assess the exposure of UFPs and characterize the particle distribution. Possible predictors of exposure were investigated using linear mixed effects models. Exposure to UFPs was highest during abdominoplasty and lowest during hip replacement. 70% or more of the measured particles were in ultrafine range. The use of electrosurgery resulted in short-term high peak exposure with a maximum peak exposure of 272,000 particles per cubic centimeter during a breast reduction surgery. The peaks corresponded to the use of electrosurgery unit. Nephrectomy, transurethral resection of the prostate, which is otherwise known as TURP, and hip replacement surgeries produced the smallest size particles, 9 nanometers, and also had the highest percentage of UFPs. So UFPs are ultrafine particles. Breast reduction surgery and abdominoplasty produced larger size particles and had lower percentage of UFPs. And there were no significant differences in exposure among the team members. The researchers concluded that the use of electrosurgery resulted in short-term high peak exposures to UFPs, and recommended the correct use of smoke evacuators. The use of built-in smoke evacuator tubing on the electrosurgery pencil, and the use of 2 smoke evacuators if 2 electrosurgery pencils are required. Basically, I don't think with a TURP, transurethral resection of the prostate, you can even use a pencil, because basically you're putting a cystoscope, I think, into the urethra, and then you're also then from the cystoscope, I think you're putting a loop in through that cystoscope, and that's what's actually cauterizing inside the past urethra into the prostate, and then that plume puffs out through the urethra, and obviously through the penis. Usually, unless they've lost their penis in cancer, but that's where the plume comes out into the room after the prostate within the urethra has been cauterized. And obviously there's a lot of particulate matter. And the problem is these smaller particles, they're more or less known as nanoparticles. And that is cancerous, that can be very cancerous, causing substances. When you analyze fine particles in surgical smoke by time distance during urology procedures, as Wang did on a different study, the 3 types of surgeries included in the study were open surgeries, laparoscopic nephrectomy, and TURP. 3 subtypes of the open surgery, according to surgery depth, were inguinal lymph node dissection for penile cancer, superficial, partial nephrectomy, abdominal, and radical prostatectomy, pelvic. The sample size of each group was 5 patients per surgery. All procedures were performed in the same laminar airflow room. An instrument using a laser light scattering technique measured the number of particles. The particle counts were expressed as concentration per 0.1 cubic feet. The instrument calculated an adjusted measurement of PM mass micrograms per cubic meter. Particle counts were measured at 40 centimeters, 60 centimeters, and 120 centimeters during open laparoscopic surgeries to simulate the positions of the surgeon, assistant, and scrub person, and were measured at 40 centimeters during the transurethral surgeries. During the open surgeries, PM, and I guess PM would be considered fine particles, was measured with and without wall suction for smoke evacuation. To evaluate the air quality, the researchers used Air Quality Index, National Ambient Air Quality Standards for particle pollution revised by the U.S. Environmental Protection Agency. Background particle measurements in the OR before surgeries were nearly 5 micrograms per cubic meter. The AQI of the air 40 centimeters from the open surgery incisions turned to unhealthy and very unhealthy in 3 to 6 seconds. In laparoscopic surgeries, the AQI 40 centimeters from the trocar reached hazardous levels in 3 seconds after the trocar valve was opened, releasing the surgical smoke. In the transurethral surgeries, the AQI was moderate, 40 centimeters from the resectoscope. Use of wall suction decreased the inhalation dose of fine particles 48% in superficial surgeries and 52% in abdominal surgeries. The main finding of this study was that the concentration of fine particles of a single smoke plume could become very unhealthy for the surgeon. The researchers concluded that increasing the distance to the incision site decreased the concentration and inhalation of fine particles, and the use of smoke evacuation can reduce the concentration of fine particles. Furthermore, HPV. HPV, the evidence regarding the presence of HPV in surgical smoke is inconclusive. Human papillomavirus has been detected in surgical smoke generated by lasers and ESUs during treatment of genital infections. Varicae, I'm not sure what that is, but laryngeal papillomavirus and bovine papillomavirus induced cutaneous fibropapillomas. However, some studies have found no detectable HPV in laser plume generated during treatment of laryngeal papillomas. Kashima conducted a prospective study to determine whether HPV DNA was in the smoke plume after CO2 laser treatment of recurrent respiratory papillomatosis. Why do I always want to say Hakuna Matata? Hakuna Matata, papillomatosis. 22 patients with diagnosis of adult onset. The researchers collected 30 paired tissues and smoke samples during microlariнгoscopy with CO2. So if you're following along here, I'm in obviously the guidelines, and it's free to the public. It's the 2017 guidelines for perioperative practice. It's surgical smoke guidelines, 2017 guidelines for perioperative practice, and it's free online. Everybody needs to print out the copy. And so anyway, it's bad stuff. And Kashima basically says to reduce the risk of potential infection to the patient and perioperative team nurses, they recommend using PPEs. PPEs stand for personal protective equipment. Now, wouldn't PPD be better than PPE, personal protective devices? But they want PPE, but PPD sounds better. And a gas scavenging system, whenever viral infected lesions are treated with a CO2 laser. In a prospective study, Hughes and Hughes collected and evaluated the laser plume of erbium, YAG laser treated human warts, to determine the presence or absence of HPV DNA in the plume. The researchers excised half of 5 patients' Verruca vulgaris and submitted the specimens for histopathological diagnosis and HPV DNA detection within situ hybridization for HPV. The remaining half of the Verruca vulgaris were ablated with the erbium YAG laser, and a smoke evacuator collected the plume for evaluation of HPV DNA by PCR with consensus primers for the HPV previously detected in the Verruca vulgaris specimens. The histopathological diagnosis of all 5 specimens was Verruca vulgaris. All of the specimens with in situ hybridization contained HPV2 DNA using PCR with consensus primers for HPV2. The researchers did not detect HPV2 in the laser plume of the same specimens. They concluded that the negative HPV plume results with the erbium. The YAG laser were contradictory to the positive HPV plume findings in the 2 other studies, in which CO2 laser and electrosurgical excision and CO2 laser excision were used. Hughes and Hughes postulated that the negative results could be a result of the radical explosive ejection of the erbium. YAG laser disrupting the HPV and rendering it undetectable. Studies by Bergbrandt et al., Sud et al., and Sawchuk describe the risks of HPV exposure from ESU-generated smoke. And I guess ESU would be electrosurgical units. I'll get into the HIV, the blood, a little later, but obviously they've said that the researchers in various studies have concluded that infectious HIV could be isolated from cool aerosols created by HIV-1 positive blood exposed to orthopedic routers and oscillating saws, but that high temperatures of the electrocautery may inactivate HIV. So the high temperatures usually will kill HIV. When possible, the perioperative team should use the highest level of control. If the hazard cannot be eliminated, the team should employ the next level in hierarchy. The healthcare organization should determine the hazards hazard exposure to the perioperative team by the job classifications that the team members at risk, number of procedures where surgical smoke is generated, number of procedures where surgical smoke is not evacuated, type of energy generating devices used, number of smoke evacuators available, number of ORs needing smoke evacuation, and current usage of smoke evacuation soft goods, smoke evacuator tubing, smoke evacuator filters, inline filters, and laparoscopic filters.
Had the $1 million policy, his entire, for the last 40 years, it's been $1 million policy.
So,
why would it change?
in disease transmissible cases, HPV, the perioperative team may use fit-tested surgical N95 filtering face piece respirator in conjunction with smoke evacuation. A fit-tested surgical N95 filtering face piece respirator does not replace the need to use a smoke evacuation system as the first line of protection against the hazards of surgical smoke. So even if you have a PPE, personal protective equipment, which is, you know, a mask, you're also going to need a smoke evacuator. Respiratory protection for aerosol transmissible diseases is based on the pathogen and anticipated risk associated with the procedure. Also, recommendation 2, the perioperative team should evacuate all surgical smoke. Okay, that's their recommendation number 2, and that would be a surgical smoke evacuator. Furthermore,
Prior policy,
there's carcinogenic hazards, there's mutagenic hazards, there's cytotoxic hazards, there's viral hazards. One study developed a model system to test the possibility of virus transmission during excimer laser treatment through airborne excimer laser debris. An excimer laser was used to ablate a culture plate infected with pseudo-rabies virus. Pseudo-rabies virus is a porcine enveloped herpes virus, similar in structure and life cycle to HIV and the herpes simplex virus. In vitro transfer of viable pseudo-rabies virus by excimer laser plume did not appear to occur. The researchers concluded that the surgeon and the team members are at low risk of infection by enveloped viruses transmitted by the excimer laser plume. We have bacterial hazards and patient health effects. 2 studies report potential hazardous effects to patients from surgical smoke exposure. Freitag investigated the harmful effects of surgical smoke inhalation for the patient and the OR team in an animal study. To simulate a single patient exposure of the respiratory system during a procedure, the researchers measured the effects of 1 10-minute exposure on airway resistance, gas exchange, and mucociliary clearance rate in the trachea to simulate the repetitive exposures of surgical smoke inhalation by the OR team. The researchers measured the effects of 3 separate 10-minute exposures on airway resistance, gas exchange, and mucociliary clearance rate in the trachea. They found a decrease in arterial particle pressure of oxygen after smoke inhalation. Tracheal mucus velocity was significantly depressed in a dose-dependent manner with increasing smoke exposure.
Any bad?
Quite a few
I'll
studies.
get with it.
So,
But that's what I'm guessing.
in a prospective study, Neshat analyzed the blood samples of patients undergoing laparoscopic procedures with accompanying laser and bipolar ESU smoke generation. Carboxyhemoglobin
Greg Barnhart.
concentrations were measured with gas chromatography.
From the defendant?
Preoperatively, the mean carboxyhemoglobin and postoperatively, the decrease was statistically significant. The researchers concluded that carbon monoxide poisoning is not associated with laparoscopic procedures. They attributed the results to aggressive smoke evacuation that minimized the patient exposure to carbon monoxide and to active elimination by ventilation with high oxygen concentrations. Very strange. To determine the absorption of carbon monoxide from the peritoneal cavity,
If it turns out to be
measured
$4 million,
patients' preoperative,
40% of
intraoperative, and postoperative levels
that comes to me.
of
So I get 25,000.
carboxyhemoglobin
$250,000, I got 25,000.
in the control group. No lasers or no smoke generating devices were used during the laparoscopic procedure
So I'm expecting
in the-
25,005.
in the experimental group.
So what happens if something reloaded?
Lasers were used during laparoscopic procedures. Patients were screened preoperatively for environmental or occupational sources of elevated carbon monoxide. The patients were evaluated for carbon monoxide levels before induction of anesthesia, periodically during the procedure, and postoperatively at 2, 3, 6, 12, and 24 hours.
I'm hurt that badly.
Yeah.
And they say, sorry, you only got 250. We're not.
Recommendation for the third recommendation
You sue them for
in
bad faith.
surgical smoke safety. Perioperative team members
First get the judgment
should
against the
receive
driver who
initial
caused all
and
of it.
ongoing education and competency verification on surgical
Bad
smoke
faith, and
safety.
they award you not only the million, but all your-
Perioperative team members should receive initial and ongoing education and competency verification on surgical smoke safety. Initial and ongoing education of perioperative team members, facilities to develop of knowledge, skills, and attitudes that affect safe patient care and workplace safety. I'm just going to say it again. The third recommendation is perioperative team members should receive initial and ongoing education and competency verification on surgical smoke safety.
When you're talking about
Policies and procedures for surgical smoke safety should be developed and reviewed periodically, revised as necessary, and readily available in practice setting in which they are used. Policies and procedures for surgical smoke safety, this is recommendation 4, should be developed and reviewed periodically, revised as necessary, and readily available in the practice setting in which they are used.
They have
Recommendation 5,
old school signatures.
perioperative personnel
Very articulate.
should participate in a variety of quality assurance and performance improvement activities that are consistent with the healthcare organization's plan to improve understanding and compliance with the principles and processes of surgical smoke evacuation. Once again, okay, quality assurance and performance improvement programs assist in evaluating and improving the quality of patient care and workplace safety, and in formulating plans for corrective action. These programs provide data that may be
My
used
baby's sick.
to determine whether
But I
an
don't
organization
go out there and see her
is
because
within
she
its
is sick.
benchmark
I
goals,
don't get what she
and if not, to identify areas that may require corrective action.
I don't know.
That's their
Days to see if I get
5
sick.
recommendations.
Then if
Uh,
I'm nauseated, then of course.
It's amazing.
I would,
Amazing. And
Please don't.
anyway, let's see here. So I'm going to go through this and tell you number 70.
I just signed myself up for.
Number 70 was surgical smoke and ultrafine particles. That was Brust, Hallfield. Then we had Wang in 73.
Yeah.
Evaluation
Okay.
of fine particles in surgical smoke from a urologist's operating room by time and distance.
Get out of your comfort zone.
It's these are great studies, and this surgical smoke safety guideline is wonderful, and it has 5 recommendations. And I'll just go through the recommendations one more time. Obviously,
well,
Very important though.
let's see here. The first
I
recommendation
didn't know that would happen.
is
What?
the healthcare
I
organization
didn't know that that's what was happening with him.
should provide a surgical smoke-free environment.
I didn't know that.
The
I thought the prostate.
nobody did.
the second let's see, the second recommendation is the perioperative team should evacuate all surgical smoke.
What?
And then
That
the third
the inside
recommendation by AORN
And they don't, they're.
is let's see here.
My brother David never did.
Recommendation 3,
Every surgeon-
perioperative team members should receive initial and ongoing education and competency verification on surgical smoke safety. Recommendation 4, policies and procedures for surgical smoke safety should be developed, reviewed periodically, revised as necessary, and readily available in the practice setting in which they are used. Now, recommendation 5,
Well,
perioperative personnel should participate in a variety of quality assurance and performance improvement activities that are consistent with the healthcare organization's plan to improve understanding and compliance with the principles and processes of surgical smoke evacuation.
I know.
And that's all I got time for today. Thank you for your time, and hope you have a good day.
He was saying he was doing surgical removal of prostate with some of that virus